So this morning we're going to talk about the administration of medications via injection, and we'll also talk some about needle safety. And so we've got, I set up a couple of different types of objectives for us today because we are going to transition over to the lab. So there are going to be some hands-on things that you're going to want to learn. So we're going to need for you to be able to describe and demonstrate the techniques used to administer injectable medication via the intradermal, subcutaneous, and intramuscular routes. Demonstrate the correct infection control concepts during injectable medication administration, and select appropriate equipment necessary to safely administer injectable medications based on the route, the medication, and patient-specific factors. What do you think I mean when I say patient-specific factors? Okay, their size, their weight, their body composition, and their age. I've worked with adults almost exclusively throughout my career as a nurse, but I think Charmaine does pediatrics, and so our selection for needles and the amount of medications that we're going to feel comfortable giving as an injection are going to be vastly different. And so that's one of the things that we're going to need to try to focus on today, is also letting each other kind of share details about our experiences, because you guys have experience. And so Charmaine would kind of be my resource person for how to give baby shots, because I would just totally lose it. But, you know, Amber might say, well, I know elderly folks, and I kind of know the things that are specific for those. So we'll do a little sharing as well. I want you guys to participate in class discussion, share those previous experiences, and recognize the importance of and identify proper action to take to maintain a safe environment in relation to injectable medication administration. List and describe common routes of injectable medication administration, for example, the intradermal, subcutaneous, and intramuscular routes, and compare and contrast the injection site, anatomical landmarks, rationale, and necessary equipment for injectable medication administration. So I gave you guys a compare and contrast table that you can kind of take notes on as we go through all these things, because I have it broken down into sections for you. And then that way it'll be a nice little study tool for you for the quiz for later, and also for your lab check-off. Just a nice little visual thing to put it all together. All right, and then basically our outcome is we want you guys to be able to be successful in your ability to select different needles, keep yourself safe when you use a needle, and to be able to perform various types of injections across the lifespan for different body compositions. All right, so our universal basics for all injections, Dr. Time. So what are our 7 rights again? Right. And for injections, your documentation, you're going to specifically include your site, right? Because especially for things that are going to be recurring injections, you're going to need to know where the last person gave the injection, so that you can either stay in the anatomical region for your rotation or move to a totally different site. You want to be able to go back and look at that location later to make sure that there's no complications from the injection. And then, you know, just want to be sure that you chart your site. Patient privacy. So we don't want to give each other injections here in the middle of class. It's not the flu pod, especially if it's going to be in a sensitive area, the thigh or the gluteal region. So you want to be sure that your patient's in a private curtained area. Hand hygiene, as always, we're going to do either washing our hands or use of the hand sanitizer. Put gloves on to give all of our injections, and then once we're finished, take the gloves off and do the hand sanitizer on the way out. Prep. So there's several different things that you need to consider for preparation for your injections. The medication itself, you want to do your dosage calculations and make sure that the amount that you're going to inject is appropriate. You know, the amount that you're going to put into an intradermal injection is way less than what you can put into an IM injection, right? And the other thing that you want to consider is, you know, even though you can give larger volumes with those IM injections, there's still a cutoff point. There's still a ceiling limit on that. So I think your book actually tells you that if you need to calculate the dose, if it's not something that's like a pre-filled thing, you're going to calculate it and you're going to recheck your math 3 times to make sure that what you're going to give is the correct thing. Your equipment, you want to be sure that you're selecting the appropriate size syringe and the appropriate size needle, and that's based on what you're going to give and who you're going to give it to. And then you're going to prep your site, clean it with the alcohol. We're going to just go over all these one time, and we're not going to mention them again in between each individual thing. We're going to just kind of expect that you're going to know you're going to do your hand hygiene and clean your site before you give any sort of an injection. Administering your medication, you don't want it to take too long. Quick dart-like procedure when you're going to give the injection, and then disposal of your sharps. Alright, so we'll start with intradermal injections. Intradermal injections are made into the dermal layer just below the epidermis. Most of these illustrations are the ones that are from your book, from your pharmacology book. So we're going to use the very thinnest needle that we have. The tuberculin type syringe is a great syringe to select for intradermal injections. A 26 to 28 gauge needle, and it's going to be a short needle, 1/4 inch to 1/2 inch long. The angle of insertion, very shallow, 15 degrees. You're going to get it right up under the skin, and you're also not going to insert the needle very far. You're only going to go about 1/8 of an inch into the skin. The solution amount is very, very small, 0.01 to 0.1 milliliters. And so you'll see on your TB syringes that they're calculated, or they're metered out in hundredths. And your book also makes mention, and also the NCLEX book makes mention of when you're going to adjust and calculate your dosage for adults or pediatric patients. Your pediatric patients, you want to go to the hundredths mark, and for your adult patients, you're going to go to the tenths. So what are intradermal injections used most commonly for? What have you guys used it for in your practice? Okay, your TB skin test that you can keep practicing as a nurse. Other things that it's used for, allergy testing. So the intradermal route has the longest absorption time compared to the subcutaneous and intramuscular injections. As a result, it's used most commonly for sensitivity tests, allergy tests, and for local anesthesia. You know, if you ever had those patients that ask, can I get a little shot of lidocaine before you do my IV? So those would be intradermal injections. All right, sites for the intradermal injection. They need to be smooth, flat, preferably hairless, and areas that receive little to no friction from your clothing. So the inside of the forearm, the inside of the upper arm, across the flat part of the chest, and across the scapula are great areas to select for those. But also pick something that's appropriate for what you're giving. You're not going to ask your patient to give them their TB skin test on their scapula. You're gonna go for this one. But the scapular and the chest regions are used most commonly for like allergy testing. And so what's the thing you want to look out for if that's what you're using it for the allergy testing, or really for any intradermal injection? What are you going to come back in 20 minutes, an hour, or 2 days and look for? Adverse reaction. And what's that called? That wheel and flare. And I think your book grades it out as a +1 to +4 based on how red it is, how raised it is, and how big your circle of redness is. And I think it was on the previous slide. Just remember, when you're instilling the medication, you want to get the nice little hump there as you inject it, and that's called a bleb. It always makes me think of how dogs talk, blebs and blims. But all right, so I've got a brief little video for you on how to do the intradermal injection.
The following has been made possible with a grant from the Lincoln Financial Foundation.
Intradermal injection. Cleanse the area with an antimicrobial swab. Use a firm circular action moving outward from the center. Let the area dry. Remove the needle cap by pulling it straight up. Hold the skin taut with your non-dominant hand. Hold the syringe in your dominant hand between thumb and forefinger. The angle of intradermal insertion should be between 5 and 15 degrees. It will be almost flat against the skin. Dart the needle into the tissue quickly. Insert the needle about 1/8 of an inch deep into the tissue. Once needle is in place, use thumb and forefinger of the non-dominant hand to keep the lower end of the syringe steady. Slide your dominant hand to the end of the plunger. Inject medication slowly. While injecting, look for a small wheal or blister to appear. Withdraw the needle smoothly at the same angle of insertion. Apply dry gauze with gentle pressure. Do not massage the site. Do not recap the used needle. Engage the safety shield or needle guard. Discard needle and syringe into the appropriate receptacle. Assess patient's response to medication.
What's a specific consideration you might want to have for your pediatric patients for intradermal injections? Like if you're in an allergy clinic, do kids want a whole lot of shots? Are they going to have a lot of fear and anxiety about the fact that you're going to do the grid on their back and give them probably 10 to 20 injections? So that's something that you want to just have as an age-specific consideration for those patients. You know, that doesn't mean that it doesn't also apply to your adult population. There's adults with definite needle fear, but I think it's probably something that you more heavily see with pediatric patients because a lot of pediatric patients do get the allergy testing. Any questions about intradermal injections? Okay. All right, we'll go to subcutaneous injections next. All right, and the subcu injections are made into the loose connective tissue between the dermis and the muscular layer. So we're down here in our fatty layer. The needle gets slightly bigger, 25 to 29 gauge, still pretty tiny, 3/8 to 5/8 of an inch. Depending on what you're going to give and where you're going to give it, 45 to 90 degree angle is appropriate. And it's again a smaller solution, 1/2 ml to 2 milliliters is appropriate. Sometimes you'll find where Mrs. Shore and I work, we give filigrestrium, which is a growth factor to stimulate neutrophils. And sometimes those patients will have really large amounts that they're going to get, like you'll calculate the dose and it's like 4 milliliters. So are we going to give that all in one shot? No. So even though it's inconvenient for your patient because they need 2 shots, it's the safest way to proceed with that. So just 2 milliliters in a different site. Drugs administered into the subcutaneous tissue, absorption occurs more slowly and the drug action can be longer than those given in the IM route because there's a decreased vascularity in the subcutaneous tissue. Drugs given in this route need to be very soluble and potent because they are given in such small amounts and they should not be excessively irritating to the tissues. So if you think about that, that makes sense. You know, when you look at how much insulin you give a patient, it's a pretty small amount. All right, and then these are the sites for your sub-Q injections. So fatty part of the arms, they're very similar to the intradermal injections actually. The scapula on the back, the upper region of the buttocks, around the abdomen, and then the upper surface of the thighs. They're given in areas that have ample adipose tissue. The American Diabetes Association recommends that you rotate injection sites systematically in one area before moving to a new site. So what the American Diabetes Association suggests is that If you look at this circle, there's a 1, 2, 3, 4, 5, 6. And so they're saying you should give everything in this region before you pop over to another site. And then before you pop over to another site. Do a lot of people normally do this in your practice? We really don't, do we? You know, we'll say, where'd you get your insulin for breakfast? I got it in my left arm. And then what do? Go to your right arm. And so what they actually suggest is that you stay in one region, rotate around, and then move to another. So what are some things that you want to monitor that site for especially your diabetics that are going to be getting injections 4 times a day, every day for 30 years? What? Dimpling. Okay. And so you want to look for that. That's considered lipohypertrophy or lipoatrophy. And so that's that dimpling and hardening of those fat cells, and that can decrease and minimize your absorption of insulin. Does it matter where you give it as far as your absorption goes? Do any of the sites absorb faster than the others? They do. Your insulin is absorbed more quickly in the abdominal region, and so then that's followed by the arms, the thigh, and the buttocks. Any questions about sub-Q? I didn't put a video for this one. It's pretty straightforward. Alright, IM injections, and this is where your little sticky dots come into play because we're going to find sites on each other just for practice. Alright, so IM injections are made by penetrating through the dermis and the sub-Q tissue and going into the muscle. So they are very deep injections. You want to use a larger bore needle, a 20 gauge or a 22 gauge, and depending on the viscosity of your medication, you might have to go even bigger than that. Has anybody ever given Bicillin LA? It's like Elmer's glue. It is really thick. It is really hard to get it out of your syringe. Charmaine is nodding her head. And it hurts. Yeah. You have to use a... Yeah, it's usually like an 18 or a 21 gauge that you end up with for those. It's pretty big. So long needles, 1 to 1.5 inches. If you have a patient that has a lot of adipose tissue that you're trying to get through, you may even have to go a little longer than the 1 inch, the 1.5 inch. Angle of insertion is going to be 90 degrees, and so when we give the IM injection, we're going to spread that tissue out so that we're flattening out all the fatty tissue to get into the muscle as deep as we can. What's something that you want to avoid when you're choosing your needle length on your patient? Too long of a needle, and why? Exactly. When you're for flu vaccines, my manager at the time, she was a very thin, very frail lady. She had the body composition of an elderly person, even though she was much younger. And so going through the flu clinic, you know, they already have everything kind of preset. And so they just went through, they gave her the same injection they gave everybody else, and she's like, my arm really hurts. And then by the next day when she came back to work, she couldn't lift her arm. And they had hit her bone with that injection. It was a very, very long ordeal for her. The amount of solution, this is where your solution amounts vary drastically in between adult and pediatric patients. So 1/2 milliliter is kind of your standard starting point. A lot of vaccines kind of come pre-filled as 1/2 ml, but then it varies more greatly for your antibiotic injections. So the ceiling limit for adults is 3 ml. Now most times the cutoff point is going to be listed as 2, but the absolute ceiling limit is going to be 3 ml for your adults. And for pediatric patients, it's 1 ml. And so this is just like with your sub-Q injections. If you have to give more than the recommended amount, you're going to want to divide that dose out and give it in 2 or more shots. So absorption of medications occurs more rapidly in this injection site because it has a rich blood supply. Your patient age, their size, and their body composition matter the most when you're selecting your IM injections. Alright, so we've got a few videos to watch and we'll practice a little bit. So this first one's for your vastus lateralis. Who do you use this site on the most? Babies. I don't think I've ever given an adult a shot here, but it's actually a really convenient area.
When locating the vastus lateralis site for intramuscular injection, follow these steps. Position the patient lying supine or sitting. Locate the greater trochanter and the lateral femoral condyle. Place your hands on the thigh with one hand against the greater trochanter and the other edge of the hand against the lateral femoral condyle. Visualize a rectangle between your hands across the anterolateral thigh. The index fingers of your hands form the smaller ends of the rectangle. The long sides of the rectangle are formed by drawing an imaginary line down the center of the anterior thigh and also by drawing another line along the side of the leg, halfway between the bed and the front of the thigh. This box marks the middle third of the anterolateral thigh, which is the injection site.
Sometimes there are special situations that you will encounter during the procedure. What if the patient is a child? What is the best site to give an IM injection? Because the infant's muscles are not fully developed, site selection is limited. For children who are walking, use the ventrogluteal site. For children who are not yet walking, use the vastus lateralis. Once the gluteal muscles are developed further, which occurs with walking, the ventrogluteal site can be used.
All right, with your partner, locate that site for me.
I got another right here. Yeah, find it real easy. She had touched my thigh before. You go like this, and just imagine this thing. And she had right there.
We got jokes about that too. We're just full of.
That's still wrong.
Ooh, Skittle Pops. I hadn't thought about that. Ooh, a whole different discussion. Okay, so any questions on that injection site? Okay. All right, so just another question before we move to the next injection site. When you're doing your IM injections, do you aspirate for blood or not? No, we do not do that anymore. We used to do that. We used to do that all the time. And then they decided that, number one, it wasn't very effective because what do? You're in there and you want to just get the injection over with so quickly that you just give it that quick little pop. And people weren't really, able to see if they had a good blood return or not. It's more painful for the patient, and you're probably more likely to do some tissue damage to your patient, and just freak your patient out if you take way too long trying to do that. So it's just an old practice, and so if you find someone in your practice that's still doing that, gently just let them know, hey, you know what? We've decided we don't do that anymore. All right, we're going to do the gluteal sites. And so when we talk about these, pay special attention because there are significant differences in your landmarks, number one. And when I went to nursing school, we relied very heavily on the dorsal gluteal. And this one is really falling out of favor these days. So we'll go over both of these and then we'll practice some.
Dorsogluteal injection site. Place client in prone position. Identify greater trochanter by placing hand on site. Now, identify the posterior superior spine or prominence of the iliac crest. Draw an imaginary line between trochanter and posterior superior iliac spine. Locate injection site above imaginary line drawn between the two bony landmarks
This site will prevent injury to the sciatic nerve. Inject medication into dorsogluteal site at 90-degree angle.
Alright, do you all feel comfortable practicing this on someone else?
Okay. Now. I don't know where it's at.
Remember, you want to put the palm of your hand on that greater trochanter to find one landmark.
Okay.
And then you're going to use the other hand to trace up to the top point of that iliac crest. So there and there, and then you're going to draw your line across, and then go above it. Yep. Right. More to the side. Yep. Yep.
Good. Okay. No, right? I say, ooh, girl. She's up back there.
It's usually higher than what you would expect it to be.
Yeah, yeah, it
Oh, you
is.
need a sticker.
And that's the reason why they recommend that you put your patient in the prone position, lying face down, because your body composition shifts a lot when you lay down and stand up, right? And so when you're laying down, it helps kind of smush that fat around on your buttocks a little bit and helps it fall forward, and so it makes that side a little more prominent, number one. It's easier for you, and the patient's less likely to run away from you if you've got them laying down because you're going to stab them in the buttocks, right? So for the dorsogluteal, do not use it in small children. Don't use it in babies. Don't use it in infants. I think your book actually recommends to not use it in children under 3. And it's because, as the gentleman on the first video said, they're not walking, and so they don't have those gluteal muscles developed, number one. And in children, I think there's a great illustration in your book. If you look at the branching of their sciatic nerve, it's way higher than it is on the adult in that model. So, you don't want to hit that structure and impair the baby's ability to walk once they get old enough and able to do that. What's another thing that's kind of wrong with giving things in the dorsal gluteal muscle? What do you see that could be an issue there? Hit the nerve, hit the bone, would you say? Yeah. Some people brace with a little more in the back area. I don't have a lot back there, but there are some folks that have a lot back there, and so it makes it a little harder, and you're going to have to use a longer needle on those folks, and it's less reliable that you've actually gotten into the muscle. Especially if you think about these ladies that go and have all the Brazilian butt lifts and things are shifted to a different position. I watch botched all the time, and those surgeons will take and they'll flip their fat flaps from their back down onto their gluteal region, and so that's just a whole different anatomical equation that I don't feel like is safe in my practice to do. So dorsal gluteal, you can use it, but it's not the preferred area anymore, but we'll still go over it because it is actually a great site to do the Z-track, and I think the book actually recommends that that's where you place your Z-track because it is so deep. Alright, we will move on to the ventral gluteal. I will be honest and say I have never given an injection in this site because I feel like it's a harder one to find, but now that I've reviewed it, I plan on trying to incorporate it into my practice. Has anybody ever given an injection in that site? Yeah?
Location of iron sites. Ventrogluteal injection site. Place client in side lying position. Use right hand for left anterior hip or left hand for right anterior hip. Identify greater trochanter and place palm at site. Keep palm on greater trochanter and point index finger toward client's anterior superior iliac spine and fan out other 3 fingers. Form V area with index finger separated from other 3 fingers. Inject medication at 90-degree angle within the area.
Question. What about like with our older folks, when they start losing that muscle mass there, would that be something we would kind of avoid at that point?
Yes.
Because I mean, and some of the men too that I'm thinking, like the way their quadriceps go, I'll be curious as to how. We'll have to look at our families this week and check everybody out and see the different types, because I personally never use that either.
I mean, and if you think about, like Ms. Shore was saying, for your older folks, maybe folks that are, have less physical capabilities, maybe they aren't ambulating as much, these muscles aren't getting worked. And so if they're not getting worked, they're getting atrophy. And so, number one, it's a less desirable place because it's not gonna probably absorb as well, but also there's gonna be that atrophy that's gonna increase the risk of you hitting the bone. You're not gonna have that locomotion to help them absorb the medication. So those are all very good factors to consider. Thanks for bringing that up. You said you've got experience using this injection. You want to talk to us a little bit about it?
They use it like during cold season, family medicine.
Okay.
When people are getting like callos or something.
All right.
And it's only if your doctor tells you that time.
I'll get it. Do you think it's an easy site to find? Okay.
No, because people are already bashful about having to pull their pants down, so if they can pull their pants down far enough, and you're like, I gotta get there, so it's just easier to do it somewhere.
Now for this one, it did recommend that you have the patient in the sideline position. Again, it's going to help us move all that extra adipose tissue down to a more dependent portion of the bed. Maybe will help your patient to relax that muscle a little bit. So if you guys don't mind, you'll all assemble and practice again. We can practice in the standing position.
Right? So we get you both. No, I'm trying to release form before I started. There's my phone. You're excited now. It's in there somewhere.
It's got a little squish, mine's got some squish, but I don't know about getting a shot in it.
I'm just, it's like right there at the end. I'm just nervous.
All right.
Oh, yeah, okay, I was like, oh, for shot split.
Charmaine, do you find this is an easy place to use for pediatrics? Okay.
Because you can't get through that.
I was gonna say, there's probably a lot of wiggling and squirming that goes in with the pediatrics.
Get your plugs on.
All right, and this will be our last IM injection. This will be the deltoid. Probably one of the most easily accessed and heavily used, but remember with the deltoid, smaller volumes. Okay, you shouldn't exceed 1 milliliter in your deltoid injections.
Deltoid injection site. Expose the client's upper arm. Place one hand on the acromion process and the index finger of the other hand 2 finger breadths below. This forms the base of a triangle in line with the midpoint of the lateral aspect of the upper arm. Inject a limited medication volume in the deltoid site at a 90-degree angle.
All right.
Right in that fat girl, right there.
Any questions about that one? Right. Okay, then the last IM we'll talk about is the Z-Track method. It's a special IM injection that is used for medications that may stain or irritate tissues. So, anybody know an example of one of these medications? Something that may be staining or irritating? Yes, Rocephin. You've never had any Rocephin given IM before. I assure you, it will light you up. It burns really bad. And so a lot of times it's mixed with some lidocaine, and a lot of times it's given in that dorsal gluteal. So if you're going to mix your Rocephin in your dorsal gluteal or with some lidocaine, what's something that you want to ask the patient? Are you allergic to lidocaine? And also, how are you going to get home? Because if I'm going to make your butt cheek numb, and if I might hit a nerve, might that be a problem with you operating the gas or the brake? Or if I do it in your arm, you might not be able to steer. Alright, so it's a very deep IM injection. The angle of insertion for this one is 90 degrees. The solution amount, so you're going to calculate your dose, and then you're going to add half of a milliliter for an air bubble to go on top of it to help essentially seal it in. So there's the special administration thing that you have to follow with that. So you're going to locate your site, you're going to prep your site, and then you're going to use your finger to press down and then pull that skin over by 1 inch. You're going to inject with your needle, you're going to instill the solution, and then you're going to wait 10 seconds. So you're going to pull the needle out, and then you're going to release the skin. And when you do that, theoretically it's supposed to leave this trapped area where the needle was and now where your solution is, and so it won't leak back out onto the tissue. So it shouldn't irritate like the Rocephin, or it shouldn't stain like an iron injection would. Any questions about that one? Okay. Alright, so injection risks and complications. Of course, bleeding at the site, infection. So that's one reason why you survey the skin first. You want to make sure that there's no rashes, there's no lesions, there's no skin abscesses in the area that you're going to perform your injection, number one. And then you want to be sure that you're going to clean the area with alcohol. You're going to allow it to dry on its own. You're not going to fan it so it'll dry. You're going to let it do its work. And then you're going to do your injection using aseptic technique. Damage to vital structures, as we've already talked about, you can hit the bone, you can hit a nerve, you can hit a blood vessel. If you do any of those things, what should you do? Immediately report it to the doctor, right? And then, like we talked about for the sub-Q injections, the lipohypertrophy and the lipoatrophy that's caused by not rotating your sites enough. Alright, and then the last thing we'll talk about is injection and needle safety. Of course, we're going to do our hand hygiene. We're going to use our PPE. We're going to use our gloves every time. And we're never, ever, 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 ever going to recap a needle, right? How many people have ever had a dirty needle stick? Half of us in this room have. Was it through anything necessarily that you did wrong? No. Sometimes it just happens. So, the Needle Stick Safety and Prevention Act of 2000 came about through the Safe Needles Save Lives campaign that was launched by the American Nurses Association. Now, I'll just read this to you. The CDC estimates that about 385,000 sharps-related injuries occur annually among healthcare workers in hospitals every year. More than half of sharps injuries likely go unreported and mostly involve nursing staff. A report from the Exposure Prevention Information Network found that nearly half of all sharps injuries, 48%, occurred during the use of the sharp, and nearly 40% of needle injuries which involved safety needle design. The majority occurred before activating the safety device. And so now you'll see that all of your needles and all of your sharps that are used in your practice should be what's considered safer devices. And so you'll have the little activated flange that you can flip over with your thumb. You'll have the thing that you can flip up with your thumb that covers the end of the sheath entirely. You have the lancets for finger sticks that once you puncture the patient and then you release, it's spring-loaded and it covers the needle automatically. I know that this is probably something that we don't think about a lot, but this Vacutainer device, without this, there's just that needle that's exposed there that you would be puncturing in the top of all your lab tubes. And so this is another function of that Safer Needle Device campaign. And then you've got this, the clickable, retractable thing on your butterfly quilt that just pops that needle back in after you've used it. Other sticks that have occurred 11% was disposal-related activity. So how many people have ever tried to cram extra thing into the sharps box? So 11% of exposure comes from trying to cram things into overfilled sharps boxes. Activities after use and prior to disposal, such as item disassembly. So does it make any sense that once you've given an injection to unscrew the syringe from it and then try to throw it all away? No, that makes no sense at all. Don't do that. Everything should go as one piece with your Safer Needle Device clicked over it and into the sharps container, all at one time. And then 3% of injuries are still occurring from folks trying to recap their needles. And I think if you're ever in a situation like when you're mixing a drug and you have to recap, you're supposed to do the one-handed technique where you've got your cap on a table and you use one hand and you slide it under and scoop. Don't use your second hand. So part of that Needle Safety and Prevention Act says that employers must identify, evaluate, and implement safer medical devices for staff. They must maintain a sharps injury log. So that's part of that whole, if you get stuck, you have to report it to somebody because the hospital needs to keep a record of not only your health, but also how is this occurring. Employers also have to involve healthcare workers in deciding which devices are used. So you might get to go to some of those equipment fairs. Implement engineering controls for sharps disposal containers. So this is an engineering control. We got the sharps box, but the sharps box is in another box, right? The self-sheathing needles, safer medical devices like sharps with engineered injury protections and needleless systems. You've got your blunt needles. Those are like your needleless systems. Or you've got those blue connectors on your IVs. And to also train their employees on the proper usage of engineering and workplace controls to keep them safe. Alright, and so if you are exposed to a dirty needle, what do you need to do? Immediately. Wash your hands. Flush the area, wash your hands, do whatever first aid you need to do, and then, of course, report it appropriately via the chain of command. If you were going to use a needle, like let's say the Lovenox syringes, they're pre-filled now and they're spring-loaded so that after you give the injection, you keep pressing on the plunger, pops out. Okay. I've given my injection, I'm pressing on my plunger, nothing happens. What do? Discard it. You might even make an announcement in the room. My sharps device has failed. I'm going to be taking an open needle across the room, because if you're in the middle of a procedure, you know, you've got doctors that are walking around that might bump into you. You don't want to accidentally stick somebody else. So just announce it, put it all in one piece into the sharps container, and then report it appropriately so that the hospital can track it. It could just be that you got one bad syringe with a misloaded syringe with a misloaded spring. It could be that it's like a big problem and that there's a problem with that lock or something like that. All right. And that's everything. Do you guys have any questions? Okay. All right. As long as I have your email address, I'll send you a link to the quiz and the survey, and we'll pop over to the computer lab after lunch and do that part. Okay? It shouldn't take long. It's just 10 minutes. 10 questions, rather.